Most of you will simply want to know the steps in topicalizing the airway, and this is certainly one of the most important aspects of this talk. However, there are multiple other tasks which must be performed, and performed carefully and well. Otherwise, the entire procedure may fail. As I frequently say during procedures like this, the devil is in the details, and this is absolutely true. Listen, if you're not prepared to be obsessional about the details, then continue no further. The primary task is to anesthetize the upper airway, but there are also multiple supplementary tasks other than topicalization that can make a total difference between the satisfaction of success and the embarrassment of failure. This first section will be an introduction to some very essential concepts. These concepts are really important. We have to pay attention to them. After the introduction, we will consider the main event, which is conduct of the procedure. Now, this section will discuss topicalization of the upper airway, but it will include several other topics, also critical to the success of this procedure. But before that, there are some important decisions we really have to make. For example, how sedated do we want our patient to be? Do we want the patient wide awake, or should they be very sleepy? Which is safest? Which is better? Well, without a doubt, wide awake is safest for the patient. But of course, very sleepy is the state preferred by the majority of our patients. At this point, it's useful for us to refer to the modified Ramsay scale shown, and this will already be familiar to most of you. Now, there are many ways to skin a cat, and so there are dozens and dozens of variations on anesthesia of the upper airway. There are so many choices, it can be rather confusing. So let's keep it simple. My approach is relatively quick, simple, and safe. And it allows you to keep your patient at either Ramsay score 1 or down to Ramsay score 4 or anywhere in between. In the majority of our patients, it is both safe and actually necessary to sedate them for this procedure. You know, as with all medical procedures, we must be cautious, and as a general guide, it's rarely ever wise to sedate either a very breathless patient or a patient who is already very obtunded. Only you, the physician or the provider at the bedside, can make this decision. Before we can decide on how to proceed, we have to be clear about our aims, as shown on the screen. Of course, we want really good topical anesthesia of the upper airway, but there are so many other things that can go wrong, and these must be avoided. Again, the devil is in the details. We want a calm and relaxed patient, one who is still able to cooperate. We do not want our visualization of the structures obscured by bleeding, or by mucus, or hundreds of bubbles of saliva. And finally, we want an endotracheal tube that will travel smoothly along the bronchoscope through the mouth or nose and into the glottis. These aims dictate our approach and can be seen in the next slide. And these are what, I call our secondary tasks. Good topicalization, anxiolysis, nasal vasoconstriction, a good anti-sialogog effect, lubrication, and frequent reassurance, explanation, and coaching of the patient. All of these are essential. So why do we want to proceed as above? The underlying rationale for this approach is that incremental interval topicalization requires no needles, and the systemic disposition of local anesthetic into the plasma is gradual and safe. Incremental interval midazolam and fentanyl provide very good anti-anxiety and anti-tussive effect. Gradual sedation is easier to titrate to effect, and the ability to reverse flumazenil and naloxone. The ability to reverse with flumazenil and naloxone is a powerful safety factor. Coaching and rehearsal allows for more effective topicalization with a lower total dose of anesthetic. Incremental doses of oxymetazoline or phenylephrine cause less nasal bleeding. Incremental doses of glycopyrrolate will give a dry mouth, fewer bubbles of saliva, and hopefully less tachycardia. And finally, good lubrication allows the endotracheal tube to slide more easily into the trachea. This may hopefully minimize post-operative sore throat. So yes, we are embarking on the secondary tasks before the primary tasks, and this is because time is of the essence. We can use our time efficiently by embarking on these tasks in the preoperative area. It is safer to perform the primary tasks in the operating room, but we can expedite matters by commencing the secondary tasks in the pre-op area. Now, paramount, let's consider safety. When any practical procedure is performed, there are certain steps in the planning that must be performed, and it doesn't matter whether this is an induction of general anesthesia, whether it's a spinal, a brachial plexus block, or an awake fiberoptic intubation. For the sake of patient safety, we must do the following. Full preoperative evaluation of the patient, not just the airway. Check the labs. Verbal consent is adequate for awake fiberoptic intubation, but you must of course obtain written consent for the subsequent general anesthesia and the surgery. We must establish IV access, and the appropriate ABA recommended non-invasive physiological monitors must be applied. Safety is everything. First, do no harm. We must then gather the necessary drugs and equipment, confirm the immediate availability of resuscitation drugs. In this particular case, confirm especially the availability of intralipid solution for local anesthetic toxicity, and then ensure the availability of naloxone and flumazenil. Confirm the availability of suction and provide supplemental oxygen at 2 liters per minute via nasal cannulae. And then, and only then, will we commence our procedure. Now, this is a reasonable time for us to give an overview of what we're doing. We'll divide all the necessary tasks into primary tasks and secondary tasks. Our primary tasks are topicalization of the airway, and the anatomy of the upper airway dictates how this should or can be done. We divide the anatomy into the upper part of the upper airway, shown here, which is more easily accessed, and can be anesthetized by simple gargling with local anesthetic. However, deeper down, the lower part of the upper airway, now shown in the image, is unfortunately much less accessible and is anesthetized using a mucosal atomizer. So, here's a summary of our primary tasks. 2 or 3 episodes of gargle and an episode of atomization of local anesthetic. The secondary or supplemental tasks are coaching the patient, IV sedation, nasal local anesthetic, nasal vasoconstrictor, intravenous anti-silagogue, and lots of reassurance. And here are more details on these important secondary tasks. We should not begin the primary tasks outside the operating room, of course, but expedite the procedure by performing many secondary tasks in the preoperative area. So again, yes, we do commence the secondary tasks before the primary tasks, but this is a matter of economy of time. Now, continuing our overview, this procedure, and so this presentation, will be divided into 4 time periods. After a full patient evaluation, we will spend approximately 5 minutes preparing the patient in the pre-op area. Then, we will consider all the tasks to be performed in the first 5 minutes in the OR, in the second 5 minutes, and in the final 5 minutes in the operating room. Now, let's consider the pre-op area. For most patients, the thought of an awake intubation makes them extremely anxious and they may be very hesitant. But a full explanation that safety priorities dictate this need for an awake intubation persuades most patients that it is in their best interest to be very invested in the success of this procedure. This is important because the patient's ability to perform may well indeed be a deal breaker. The cooperation is essential. I'm referring particularly to the patient's ability to perform a really effective gargle and to perform a well-timed synchronized deep inspiration. All of this requires coaching and rehearsal. And further, we tend to think of awake intubation as a set of procedures that we do to the patient. But I encourage you to think of this a little differently. It's absolutely essential to win the patient's confidence and cooperation and get them to think of this as a cooperative venture, something that you will do with the patient helping you. Now, although this seems a little backwards, we begin in the preoperative area. As I said earlier, you must be obsessive about the details. And so the next section is a detailed consideration of our secondary tasks, because the battle is fought and won in the preparation. Although I refer to these as secondary or supplementary tasks, this does not in any way minimize their importance. Failure to perform any one of these tasks very well can and often does lead to complete failure of the entire procedure. All of these secondary tasks, the concept of the incremental interval approach applies. It's important, and so you can make a start on all of these tasks in the pre-op area. So obviously, let's consider sedation. There are many operators who really want to use remifentanil intravenous infusion, others who prefer dexmedetomidine intravenous infusion, and of course these can be very successful. However, I prefer to keep it simple and play to our strengths. As anesthesiologists, we're all well used to providing IV sedation, also known as monitored anesthesia care. The essence of this is to judiciously administer a modest dose of multimodal sedation. We evaluate its effect, and if necessary, we repeat the dose of sedative. This is an important safety factor, an incremental approach, titrating to effect. As anesthesia providers, we're continuously titrating dosage to effect, and when our target level of sedation is reached, we then allow the procedure to commence. Common choices for multimodal sedation are midazolam, fentanyl, and propofol. My initial sedative is midazolam, administered in the pre-op area. Then, shortly after arriving in the operating room, after all appropriate ASA monitors have been applied, I will usually administer 25 mics of fentanyl. If I want further sedation towards the end of the procedure, I will repeat this dose of 25 mics of fentanyl 5 minutes before insertion of the bronchoscope. Not just for its sedative effect, but it does contribute a really useful antitussive effect. So, fentanyl has an important place in this anesthesia cocktail. My choice of fentanyl midazolam is simply very pragmatic. During these cases, there's occasionally the possibility of over-sedation. The agents I've chosen have specific reversal agents that will act promptly, namely naloxone and flumazenil. And this is an important advantage when success of the procedure depends to an amazing degree on patient cooperation. So finally, at the end of this process, immediately before the insertion of the bronchoscope, I will administer a bolus of 20 milligrams of propofol. And depending on the patient's response, this may need to be repeated once or even perhaps twice. As mentioned above, the frequent conduct of MAC anesthesia means that we quickly become adept at judging the correct dose of propofol, and if we overdo it, we simply support the patient's airway for a few minutes and allow redistribution from the brain to lighten our patient's depth of sedation. It's very simple, and we should all be in our comfort zone doing this. Towards the end of the procedure, if the patient should become briefly excessively sedated, then take advantage of this. This is often a good opportunity to insert the bronchoscope and intubate the trachea. My personal practice is when the fiberoptic bronchoscope is in the trachea and clearly reveals to me an image of the carina, I will ask an assistant to push a very reduced induction dose, for example 50 to 80 milligrams of propofol, and some muscle relaxant. I will wait 30 seconds or so for the propofol to reach the patient's brain, and I will advance the endotracheal tube through the pharynx, past the vocal cords, and into the trachea. Now, let's move on from sedation. What about the prevention of epistaxis? Most commonly, I will plan to intubate through the mouth, but just quickly note that although I usually go through the mouth, occasionally this can prove quite challenging, intubating through the nose, as it tends to give a more direct linear approach to the larynx. Therefore, I always prepare for the nasal approach just in case. In the pre-op area, first, I occlude one nostril. I ask the patient to take a deep breath through the other nostril. Then, I repeat the process, occluding the opposite nostril. This allows the identification of the more patent nasal airway to facilitate subsequent nasal intubation if necessary. I ask the patient to extend their neck as far as it is comfortable or safe for them to do so, and then I administer 2 generous squirts of a potent topical nasal vasoconstrictor called oxymetazoline, also known commercially as Afrin solution, into each nostril. Putting the head in this position allows these drops to run down the floor of the nose, which is now oriented vertically, and it helps spread the topicalization and the vasoconstrictors. It is only kind to warn the patient that this solution will trickle into the back of their mouth and that it tastes foul. If the patient should happen to have a low blood pressure, I often choose to use 10 to 20 mites of phenylephrine into each nostril. Now, topicalization of the nasal airway proceeds as follows. Again, with the patient's head appropriately extended as described above, a 5 ml syringe containing 2 or 3 ml of 2% lidocaine is taken, held about an inch above the opening to each nostril. It's possible to administer lidocaine solution drop by drop in this position. Every few seconds or so, a few more drops until 5 or 10 drops have been administered into each nostril. Again, in this position, the floor of the nose lies in the vertical plane, and the local anesthetic solution will run directly downwards and backwards into the nasopharynx and eventually trickle down into the oropharynx. It is amazing how much topicalization of both the nose and the pharynx that you achieve. Repeat this through the opposite nostril. A small amount of local anesthetic solution administered in this way produces surprisingly good extensive topicalization. Preparing the nasal airway in this fashion is very likely to mean that you won't need to use it. But omission of this preparation almost certainly means you will need to go through the nose. Prevention of excessive salivary secretions is really paramount. Give glycopyrrolate 0.2 milligrams IV in the preoperative care area as soon as you realize that an awake fiber optic is necessary, and after you have excluded any contraindication to increasing the heart rate. Administration of an anti-sialagogue is essential, and the following indicates its importance. If the patient does have a contraindication to an increased heart rate, such as exercise-induced angina, we will need to be very careful. But I will still give the glycopyrrolate. I will commence ECG monitoring, and then I often choose to administer between 1 milligram and 3 milligrams of metoprolol or other cardioselective beta blocker. And only then will I commence the therapeutic dose of glycopyrrolate. If tachycardia becomes unacceptable, I will give additional doses of beta blocker. A second dose of glycopyrrolate, 0.2 milligrams, will be administered later in the operating room, and this shows the importance of an anti-sialagogue. Now, reassurance. Gentle, sincere reassurance at intervals during this procedure will go a long way to making the patient and the conduct of this procedure more pleasant for you and the patient. In summary, initiate secondary or supplemental tasks in the preoperative care unit, but only ever commence the primary tasks in the operating room under full physiological monitoring. You will perform at least 2, possible 3 episodes of the administration of local anesthetic by gargle, by interval increments, and a final administration of local anesthetic by aerosolization. Now, these intervals between the primary tasks provide ample opportunity for re-evaluation of the efficacy of pharyngeal topicalization and for attention to the secondary tasks such as evaluating the adequacy of sedation. But these intervals have been built into the technique and they're important. The interval incremental administration of a second dose of antisialogog, a second dose of vasoconstrictor, and the second dose of nasal 2% lidocaine all take place in the operating room in such a way as to avoid the effects or side effects of excessive dosage. Now, let's consider the first 5 minutes in the OR. The patient will be fully monitored with conventional monitors, and they will be receiving 2 liters per minute of oxygen via nasal cannula. First, we focus on topicalization of the upper part of the upper airway. Then we address topicalization of the lower part of the upper airway as follows. Primary task number 1, topicalization of the upper part of the upper airway by gargling. My approach to topicalization of the airway for awake fiberoptic intubation requires 2, possibly 3 episodes of prolonged gargling with 3 to 4 mils of 4% lidocaine. It's essential to coach the patient about the correct way to gargle. I explain that when people gargle mouthwash, they tend to keep it in the mouth and then expectorate it. And gargling of the mouth, just in the mouth for our purposes, this will not work. It's not effective. However, you can remind your patient that what many people do, many people know that when gargling with an anesthetic solution for a sore throat, you really have to gargle lower down in the lower regions of the throat that are painful. I tell them to put the head back and that this needs to be a deep gargle with the admittedly foul-tasting solution being gargled really low down in the throat, as if they did indeed have a sore throat, or as if they were about to swallow it. Aim for a nice prolonged gargle of 15 to 20 seconds, and then, when the patient can do no more, tell them to spit out half of the volume of local and swallow the rest. See the accompanying movie. Now, this procedure may need to be repeated once, maybe even twice, but it's very rare to require more than 2 gargles. So, how much more local can we give? Let's consider the possible development of systemic local anesthetic toxicity, which must be avoided, of course, at all costs. As we have mentioned earlier, most, if not all of these patients will have had some benzodiazepine on board, preferably 2 milligrams of IV midazolam, and this offers significant anti-seizure protection. Local anesthetic toxicity occurs when there is rapid systemic disposition of lidocaine with rapidly rising plasma levels going to the central nervous system and the heart. First, we must appreciate that the 4% lidocaine is a really high concentration. It's 40 milligrams per ml, and so only 5 ml of solution is potentially required for 200 milligrams to go intravenously. Systemic absorption of local anesthetics from topicalization is, of course, much slower than for injected local anesthetics. Of all the lidocaine gargled, however, approximately half is expectorated, even more. Maybe half is swallowed, and the swallowed portion that enters the stomach becomes ionized and cannot be absorbed. So, for each gargle administered, it's really difficult to guess how much lidocaine undergoes systemic absorption. Now, a critical factor in systemic toxicity is a rapid rate of rise of plasma lidocaine levels. So at this point, I do not ask the patient to perform a second gargle straight away. Let's wait a while. Why not? I busy myself with making verbal contact with the patient to evaluate their level of consciousness. I prepare equipment for the next phase of the procedure. I check the monitors and I make sure that the procedure is being well documented on the anesthesia chart. You know that I refer to this approach as incremental interval topicalization, and the delay it engenders may be the single most important safety factor in the prevention of local anesthetic toxicity. This is, of course, really, really important. You're not in a rush to do this procedure. Take your time. These compulsory pauses between primary tasks allow the opportunity to perform some of the supplementary tasks, for which, of course, the incremental interval approach also applies, such as don't be in a rush for additional sedation, additional vasoconstrictor to the nasal airway, or additional local anesthetic to the nasal airway, or even for additional anti-silog in case you get a tachycardia. Additional coaching, and last but not least, additional reassurance that the procedure is advancing well are all essential. In the next 5 minutes, I return to the patient's airway to evaluate the results so far. I take a wooden tongue depressor, I ask the patient to open their mouth wide, pop out their tongue, and I touch the back of the throat lively with the tongue depressor, as shown in the accompanying movie. Ideally, if the pharyngeal mucosa is insensate, there should be no gagging or coughing. But we are early in the process of topicalization, so do not be surprised if the patient does gag somewhat. This is, of course, the first 5 minutes in the OR. Actually, the gagging indicates that, as expected, we need a second round of gargling with the 4% lidocaine solution. After each gargle, it is appropriate to wait a few minutes and then test the result. And this is done as above. And if the tongue depressor does not elicit coughing or gagging, then I want to test a little more invasively. I ask the patient to protrude their tongue as much as possible, causing the back of the tongue to flatten. And then I take my tongue depressor, angled downwards, and I try to stimulate the lower reaches of the pharynx. If this elicits coughing and gagging, then one more gargle is required. But if the patient's lower pharyngeal mucosa is insensate, then we may be able to dispense with a third round of gargling. Note that after the first gargle, subsequent attempts at gargling may be more difficult for the patient, with spontaneous coughing and gagging. If the larynx is already becoming anesthetized, there may be elements of microaspiration of small amounts of local anesthetic solution occurring during the attempted gargle. This is in fact a welcome development. The larynx is going to sleep. Note that in patients with a cough, which is very productive of thick, greasy mucus, this can cover the pharyngeal mucosa, and it acts as a barrier to the lidocaine, and it may be impossible for lidocaine spray to access the mucosa, and so topicalization can fail. The beauty of a vigorous gargle is that it loosens and disperses this mucus layer, making effective topicalization much more likely. It's a very simple but very pragmatic approach, gargling the local. In the last 5 minutes, now we perform the last of the primary tasks, aerosolization of the lower part of the upper airway. I do not use a nebulizer or a pressurized spray can of local anesthetic. My approach is much more simple. I use a 10 ml syringe with 3 or 4 ml of 4% lidocaine attached to a mucosal atomizer device, or MAD for short, MAD, mucosal atomizer device. It's a slim, flexible, that is bendable plastic accessory, such as when lidocaine is ejected from its nozzle under pressure from the syringe. The lidocaine is aerosolized and it will deposit on the mucosa with which it comes into contact. It's very low tech and very effective. The intention here is to topicalize the laryngopharynx, the larynx itself, including the true chords, and in fact, it is even effective at topicalizing the upper third of the tracheal mucosa. Here again, though, patient cooperation is essential. I tell the patient that for the throat to become numb, they must be able to take a deep breath exactly when I tell them. First, I tell the patient I am going to say 1, 2, 3, take a deep breath now. Next, I tell the patient that we're going to rehearse it together. And I do actually want them to take a practice deep breath. I say 1, 2, 3, take a deep breath now. But then I explain to the patient that the next time round we're going to do it for real. I will actually spray some anesthetic solution, and this will make them cough and gag, and although it's unpleasant, it's brief and it's necessary, so they do not feel anything when I insert the scope. In the next part of the procedure, I am really relying on a good degree of topicalization of the pharynx. You can't get to the lower part of the airway if you haven't topicalized the upper part of the airway. I take the mucosal atomizer device and I bend this into a tight curve to exactly mirror or parallel the curvature of the patient's pharynx. In the same way that I use the tongue depressor to test sensitivity of the pharynx, I insert the mucosal atomizer device into the mouth past the base of the tongue. Now, I'm using the tip of the mucosal atomizer device to test the sensitivity of the lower part of the airway. The tip will make contact with the lower reaches of the pharynx and the larynx, and hopefully, after the previous local anesthetic gargles, it should not elicit any serious coughing or gagging. It's rare. Usually your gargles have been very effective. The tip of the mucosal atomizer device should be at a point where it is hovering an inch or so directly above the vocal cords. Now, of course, the endotracheal route is an excellent way to administer medication such as lidocaine, and some of this lidocaine will be absorbed systemically. But equally, some of it will be expelled from the body during the next expiration. And so once again, it's extremely difficult to know how much local anesthetic will be absorbed. Now, we simply wait 2 or 3 minutes, and we can anticipate excellent topicalization, even extending into the upper trachea. Now, should the synchronization of this aerosolization procedure go badly, and it appears that little anesthetic has been inhaled, it's reasonable to rehearse the patient again and then repeat the procedure. Further, we have no way of testing how well this worked, but you know what? We're going to find out soon when we insert the bronchoscope. And if there's a lot of coughing and gagging, you can pull out the bronchoscope and repeat the procedure of atomization. Up to this point, the patient has been in the sitting up position. Now we will decrease the height of the bed until the patient is in the 45-degree head-up position. If during this process the patient's tongue prolapses backwards and occludes his airway, it can be gently displaced anteriorly using the tongue lifter shown. Here is a graphic summarizing the time course of the main tasks, both primary and secondary, during the process of topicalization for awake fiberoptic intubation. We can see that sedation spans the entire time course. Glycopyrrolate administration as an anti-sialagogue will occur in the first 2/3 of the procedure, and the administration of nasal vasoconstrictor is all really in the first third of the procedure. The administration of 4% lidocaine occurs in the first, second and thirds of this procedure, and this is of course by design to prevent rapid rises in lidocaine plasma levels. This brief summary diagram should act as a roadmap or a guide for you during the physical process of administering these medications to your patient. The gaps between the administration of 4% lidocaine are crucial. This graphic represents the time course of both the changes in level of sedation during the course of topicalization and sedation for awake fiberoptic intubation, and the broken red line represents purely my suggestion as to how I perceive the plasma levels rise during this process. This is not based on any published studies. This is my best guess, in the absence of any reliable published work. This is my best guess as to what is happening to plasma lidocaine levels during the course of this procedure. The level of sedation is unarguable. We know that the level of sedation increases as we proceed through the procedure. However, the systemic disposition of 4% lidocaine into the plasma probably happens as a gradual rate of rise, interspersed by small peaks during the actual gargles or the atomization. And once again, I feel strongly that giving the total dose of lidocaine in increments is a large contributor to the safety of this technique. So, thanks for considering my approach to awake fiberoptic intubation of the airway. Please feel free to adopt any of my suggestions that you like. Omit any of which you heartily disapprove. And feel free to make any sensible modifications that you deem necessary. I hope that this gives you a starting point to create your own unique approach to this important anesthesia challenge. You know, this is essentially a very simple procedure, but it takes a long time to explain because, of course, as I said earlier, the devil is in the details, and I have to cover the details in detail so you don't fall into the traps that I've fallen into in the past in learning this technique. As we say in anesthesia, knowledge is power. And the more knowledge you have, and the greater the grasp of the details and the finer points of this procedure, the more successful you will be, and the more gratifying will be your future practice of anesthesia, particularly your management of patients with difficult airways who need awake fiberoptic bronchoscopic intubation. Thank you for listening.